Okay, so I contacted Arthur and I asked him, well, what kind of case presentations do you want? Because as you saw beforehand, I have a few. So he said, well, why don't you talk about something relating to, this flipper foot? So I said, well, I have a few, and let's see. So when do I use flipper foot? Well, these are just a couple of cases where I did, and unfortunately, there's not a lot of data and literature on the. It's really a TCC with just leaving the midfoot kind of just flapping, right? In order so that the patient can then put some weight on it and have range of motion in order for them to feel like they're at least able to move and function. So this is one patient. He was seen in other clinics as early as 2012 and by a slew of other physicians. And he had a chronic wound to that right foot. And he had approximately 5 to 6 cases before me. And right away, I know exactly what he had. He had that starting with the 5th digit amputation, and then it kept on going down the ray, and then it kept on going to the 4th, and then it just kept on going, and he still has a wound, and this is just things that I see very often. So if we're going to do any of this, we have to do some sort of tendon balancing or something in order to stop the progression of this going that way. And he was also living in a facility. And so this is what it started with in 2012. This is what it was in 2015. And I met him in 2019, and that's what he kind of looked like, right? So, of course, we were scared of osteomyelitis, and we took the MRI, and to me, it probably looked more like osteomyelitis. And so deep ulceration abutting the cuboid and lateral cuneiform bases of the third met. And so this is kind of in the not early stages of the way that I do things, but it was really before I did a lot of these flipper foot constructs. So we decided to do a TAL, tendon balancing. I wedged that bone, I put an antibiotic spacer, and I framed it, and I came back in 6 weeks and then put some bone graft. And this is my first graft. This is my first frame. You can see the antibiotic spacer in there. And then, of course, I cultured everything and MRSA. I mean, of course. He also ended up having some wound complications, but we were able to heal that. And then after 6 weeks of IV antibiotics and making sure that all his labs are normal, we went in there and beamed. And this, you can see, it was part of my earlier sort of delve into these deformities, because I wouldn't use that kind of internal fixation anymore. I would use something a little bit more thick and hardy in order to make that stay, because most of the times these break, right? So that's what we kind of ended up with, but he ended up doing really well, actually. None of those screws broke. And this was his final labs in 2022. So, I'm sorry, 2019, 2020. So here it is how we started. We patted ourselves on the back, and I'm like, you're doing great. The ulcer closed, everything is good, keep walking. And we ended up seeing, I never let these patients really go. I always tell them, come back in six months, every 6 months, let's see you. And then he started breaking down laterally a little bit more. We did maybe another debridement just to see if we can hold off on doing any more surgery, see how severe it is. But this is how he ended up in 2022. And he was getting varus deformity of the ankle joint. And so rather than coming back and doing more debridements, which I know will not work, we decided to do TCC fusion. So I ended up coming back, and this is after like a debridement, taking out the hardware, because he ended up getting infected once more. We washed it out. And then I cut a wedge out of the area of the ankle, and I put it back together. And so then eventually we came back and we did our intramedullary nailing. And so that's kind of one of the patients that I would do that flipper foot construct in order to, when I'm not going to go in there and put more beaming through the midfoot when it's already been infected once. Even if I cut out a wedge and I treat the infection, I'm not going to go back and do that. And so I feel like this is a good way in order to fix that deformity and have the patient get back to weight bearing a little bit sooner. This is another patient. And this is referred to me from another clinician, and this is kind of what she looked like. And this is a sort of bayonet deformity. And so she has a lot of hypertrophic bone formation within there. And so she also had an ulceration to the midfoot that was treated with debridements. And so we went in there and we decided to right away do that flipper foot construct. So here is what we decided to do. You have to get rid of the posterior equinus. That is what caused the talus to become declinated anyway. And then we ended up resecting the osteomyelitic bone, put in an antibiotic spacer, and then putting her in an X-fix. And then after the appropriate monitoring with antibiotics, we came back and we took out our frame and we put the intramedullary nail. And so my criteria for the flipper foot construct: severely plantar flex talus, such as in that deformity, maybe even a little bit more, and a sort of bayonet foot deformity. Probably in the patient on the top, I would more kind of lean towards that TCC fusion as a primary, whereas in the bottom case, I would assess the foot and make sure that there's no ulcerations or there's no active ulcerations and active infection, and then I would lean more towards a sort of beaming technique. And if I have a failed beaming, I tend to go also do that flipper foot construct, TCC fusion. And as you can see, I've done a few of them. And that movement there is right in the midfoot. It's not in the ankle joint. And they're able to at least use maybe a hinged AFO. Sometimes they're able to get out of that and go into a sneaker, a rocker bottom sneaker, and weight bear as normal as they can, as possible. So I think in my bag of tricks, I think this is something that I do use that has proved to be successful, at least for me. But you shouldn't completely just not treat the osteomyelitis, because all these patients, it takes a while to get them completely healed. So tips that I've learned: try not to hyper dorsiflex the forefoot, because then it will never hit the ground, and then they'll get a calcaneal gait. More weight will go into calcaneus. Calcaneal ulcerations can happen. If you also try to make that calcaneal inclination angle back to normal, if it's too high, again, a calcaneal gait, that's what I've noticed. Be careful with hypermobility of the flipper. So if you're going to take a lot or resect a lot of that midfoot, make sure that they have some sort of hinged AFO, that they're not able to hyperdorsiflex that. That can also dislocate. I tried to use my external fixator to kind of push the forefoot into the rear foot and make a non-union into that area, and that's kind of how they get that controlled dorsiflexion of that. So you have to do something of that. Patients hate pantalers, and they're not going to be able to move through it. And so this, for me, has proven in some patients successful. And so, also I had questions of how do I do my dressing changes in here. So this is what I usually put on my patients, this compressive dressing. It helps with the edema that they get afterwards. And of course, in real time, this is how my staff puts on a dressing. And that's it. Thank you so much.